Hello. So, okay, there's a problem. This no one see my view. Previously, there used to be someone. What the hell? Okay, today's our topic will be abnormal uterine bleeding. I would say not abnormal but dysfunctional. Dysfunctional uterine bleeding. Okay. Okay, this problem. It's some sort of problem. I'm not able to. Okay, now just add. Okay. Oh, I forgot. Okay, I think now we could screen. Okay, now I think we could stream alive properly. So today our topic is dysfunctional uterine bleeding. So we're going to study dysfunctional uterine bleeding today. So this book is actually Dr. Uh, Gynecology. The subject is gynecology and the book is of DC Dutta. And today we're going to study about dysfunctional uterine bleeding as a topic suggests. So let's begin with the definition. Uh, so dysfunctional uterine bleeding is defined as state of abnormal uterine bleeding. So it is a state of abnormal uterine bleeding without any clinically detectable organic, systemic or iatrogenic cause. Organic, systemic or iatrogenic cause. Pelvic pathology, example tumor, inflammation or pregnancy is excluded. Okay. So it is abnormal uterine. It is dysfunctional uterine bleeding is a state of abnormal uterine bleeding uh, where there is absence of clinically detectable organic, systemic, and iatrogenic cause. So organic, systemic, and iatrogenic cause. So what are the organic, systemic, and iatrogenic cause? Those are pelvic pathology, tumor, pelvic pathology such as tumor, inflammations, or pregnancy. So organic cause. It is important to know about organic cause, systemic cause, and iatrogenic cause. Okay, heavy menstrual bleeding is defined as bleeding that interferes with one's physical, emotional, social, and mental quality of life. Okay, so what is heavy menstrual bleeding? You might be asked, what is heavy menstrual bleeding? It is basically defined as a bleeding that interferes with woman's physical, emotional, social, and maternal quality of life. Physical, emotional, social, and maternal quality of life. Basically, the bleeding that woman that is not normal during the menstruation is normal, and it is in excessive amount is known as heavy menstrual bleeding. In this condition, the woman is obviously physically, emotionally, and socially unwell. So that was about heavy menstrual bleeding. Now let's talk about incidence. Prevalence varies widely, but an incidence of 10% among new the prevalence varies widely, but an incidence of 10% among new patients attending outpatient seems logical. The bleeding may be abnormal in frequency, amount, or duration, or combination of any three. As a diagnosis is based with the exclusion of organic lesion. Okay, so with the care and facilities to the exclusion of lesions, the incidence varies. Currently, dysfunctional uterine bleeding is defined as a state of abnormal uterine bleeding. It is a state of abnormal uterine bleeding following ovulation anovulation due to dysfunction of hypothalamus pituitary ovarian axis, which is obviously of a endocrine origin. So what we need to understand is dysfunctional uterine bleeding. In this condition, there is absence of organic and iatrogenic as well as systemic cause. The organic, iatrogenic, and systemic cause includes pelvic inflammatory diseases such as uh, carcinomas of a uterus and pregnancies, etc. Okay, and tumors, inflammation, etc. And in this condition, there is absence of those conditions such as which are tumors, carcinomas, pregnancy, but there is actually presence of dysfunction of hypothalamus pituitary ovarian axis. So hypothalamus pituitary, so it is basically endocrine in origin, and it is followed by an anovulation. So let's look at the pathophysiology. The physiological mechanism of hemostasis in normal menstruation are platelet adhesion formation of platelet plug within fibrine. Okay, there was a mistake. So I will repeat all those things because there's difficult this. Okay, there is still that noise coming out of. I don't know how does. I don't know about that noise, but I would be studying anyway. Okay, I think it is problem with this streaming software. So let's look at the pathophysiology. The the physiological mechanism of hemostasis in normal menstruation are platelet adhesions. Physical mechanism of hemostasis in normal menstruation. Okay, so we're looking at physiological mechanism of hemostasis in normal menstruation. Okay, it is due to platelet adhesion formation. Okay, due to the adhesion of a platelet, formation of a platelet plug with fibrin to seal the bleeding vessels. Okay, at first there is platelet adjacent formation, then there is a sealing of a platelet with the fiber into seal of blood vessel, then there is localized vasoconstriction as well. Vasoconstriction regions of a endometrium, biochemical mechanism involved are okay, regions of endometrium, and biochemical mechanism involved are increase in endometrial ratios of PGF2 and PGH. Okay, and so so these are the so the chemical that are involved in the homeostasis are PG2, PGF2 alpha and PGE2. The PG2 alpha causes vasoconstriction and reduces bleeding. Okay, there is increase in ratio of PGF2 alpha, and PGE2. That means there would be increased concentration of PGF2 alpha, and PGF2 alpha is actually responsible for vasoconstriction and reduction of bleeding. Okay, so progesterone increases the level of PG2 alpha. So progesterone actually increases in the PG2 alpha from the arachidonic acids. So level of endothelin, which is powerful vasoconstriction, is also increased in an ovulatory dysfunctional uterine bleeding. There is decreased synthesis of PG2 alpha, and the ratio of PG2 alpha slash PGE2 is low. Okay, anovulatory cycles are usually not associated with dysmenorrhea. Anovulatory cycles are usually not associated with dysmenorrhea. Anovulatory cycles are usually not associated with dysmenorrhea as the level of PG2 alpha is low. Okay, so we need to know the terms such as dysmenorrhea, and so I will be talking about it right now. So let's talk about polymenorrhea. So polymenorrhea is actually a condition in which the menstrual cycle is less than 21 days. So there is other term called as oligomenorrhea. In oligomenorrhea, there is the menstrual cycle which is more than there is menstrual cycle which is more than 35 days, and there is something called as oligo. So this was polymenorrhea. This is oligomenorrhea, and there is something called as menorrhagia. So menorrhagia is a condition in which there is in which the cycle is so there is no variation of a time. It is in between 21 to 35 days, which is normal, but there is increased production of a but there is increased days of the menstruation, which is more than 7 days, and there is increased production of a blood which is more than 80 ml, 80 milliliter, and there is other term called as so this was menorrhagia. There is another term which is called metrorrhagia. Okay, metrorrhagia. So metrorrhagia is a condition in which there is bleeding within the cycle. Within the menstrual cycle, there is abnormal bleeding, and we could differentiate in between the menstrual bleeding and non-menstrual bleeding. So the non-menstrual bleeding occurs in metrorrhagia. So dysmenorrhea is basically a condition in which there is painful menstruation. So anovulatory cycle are usually not associated with dysmenorrhea as the level of PG2 alpha is low. So I think this PG2 alpha is responsible for contraction of a uterus, therefore causing pain as well as pain. So since there is deficiency of PG2 alpha due to lack of progesterone in case of dysfunctional uterine bleeding, it is rarely associated with dysmenorrhea. Women with menorrhagia have menorrhagia. We have just studied about this topic. So we know that menorrhagia is a condition in which there is increased uterine. There is increased volume as well as the duration of menstruation. And in this condition, which may have low thromboxane in endometrium. Okay, there is deficiency of thromboxane in endometrium. The endometrial abnormality may be primary or secondary in coordination with the hypothalamus. Okay, So endometrial abnormalities may be primary or secondary to two in coordination in the hypothalamus pituitary ovarian axis. It is thus more prevalent in extreme of reproductive period, adolescence and premenopause or following childbirth and abortions. Emotional influences, worries, anxieties, or sexual problems sometimes are enough to disturb the normal hormonal balance. The abnormal bleeding may be associated with or without ovulation and accordingly grouped into. Okay, there are two types of bleeding: ovular bleeding and anovullar bleeding. And I think in case of dysfunctional uterine bleeding, anovullar bleeding is the common one because I have studied about. So let's look about the ovular bleeding. So polymenorrhea or polymenorrhagia. Okay, the polymenorrhea we have already talked about this topic, and polymenorrhagia is a condition in which the menstrual cycle occurs within the 21 days. 21 days, so that there is more frequent menstrual cycles. And polymenorrhagia is a condition in which the days are lesser as well as days are so the duration is so the variation or frequency is more, and as well as there is as well as the volume is more in case of polymenorrhagia. So these two are basically different term, but they are similar as well, because polymenorrhagia is a part of polymenorrhea, but yeah, you know that polymenorrhea is not the part of polymenorrhagia. Polymenorrhagia is basically a part of polymenorrhea in which there is increased volume. So the condition usually occurs following childbirth and abortion, during adolescence and premenopausal period, and in pelvic inflammatory disease. So premenopausal period and pelvic inflammatory disease. The follicular development is speeded up with the resulting shortening of follicular phase. This is probably due to the hyperstimulation of a follicular growth. Okay, the follicular development is speeded. So follicular development is speeded up with the resulting shortening of the follicular phase. So you know what is in a follicular phase? So basically, a follicular phase is one of the phases during the menstruation in which there is development of follicles. So in this ovular bleeding, there is speeding up of this follicular phase. This is provided due to the hyperstimulation of a follicular growth by this hyperstimulation of a follicular growth by follicle stimulating hormone. What the hell? So basically there is increased production of follicle stimulating hormone. Rarely the luteal phase may be shortened due to premature lysis of corpus luteum. Sometimes it is related to stress-induced stimulation. Sometimes it is related to the stress-induced stimulation. Endometrial study prior to or within few hours of menstruation reveals secretory changes. Okay, so this is polymenorrhea in case of ovular bleeding. Okay, oligomenorrhea. So oligomenorrhea, not regia. Menorrhea, regia is different topic. Primary ovular oligomenorrhea is rare. Okay, primary is very rare. It may be met in adolescence and preceding menopause. The disturbance may be due to the ovarian unresponsiveness to the follicle stimulating hormone or secondary to pituitary dysfunction. So oligomenorrhea occurs when there is deficiency of a follicle stimulating hormone on probably the follicles. So follicle stimulating hormone basically act on the there are two types of cells in ovum. There is one called as not ovum but follicles. Those granulosa cells and theca cells, I guess. Yeah. So theca cells are basically outward and utilize follicle stimulating hormone act on the follicle stimulating hormone. I think it acts on the granulosa cell. So when there is deficiency of responsiveness of granulosa cell to the follicle stimulating hormone, the oligomenorrhea occurs. So second year, so it is rarely primary, primary, and generally secondary, and it is secondary to the pituitary dysfunction. When there is pituitary dysfunction, uh, there is undue prolongation of the proliferative phase with normal secretory phase. The secretory phase is normal, but proliferative phase takes much longer time. It is probably uh, because unresponsiveness of follicle stimulating hormone. Okay, so primary cause is very rare. Endometrial study prior to the within a few hours of menstrual delivery, secretary changes. Within a few hours of menstruation delivery, secretary changes. Functional menorrhagia. So menorrhagia, we have already talked. This is a condition in which there is more production of a so functional menorrhagia is a condition in which so functional menorrhagia, ovular menorrhagia. Okay, ovular menorrhagia is quite uncommon. This is very uncommon. Two varieties are found. Okay, irregular shearing of endometrium. Okay, in case of okay, ovular dysfunctional uterine bleeding or ovular menorrhagia is quite uncommon. In this on that topic, the ovular menorrhagia is quite uncommon. Two varieties are found: irregular shearing of endometrium, irregular ripening of the endometrium. Okay, so two varieties are found: irregular shedding of the endometrium. So in menstruation, so suppose this is uterus. During the menstruation, there is menstruation because there is shedding of the outermost layer of the uterus. So 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 menorrhagia in case of of ovulatory ovular bleeding. Okay, ovular menorrhagia is probably due to the irregular shedding of this wall of the uterus, or it might be due to the irregular ripening of the endometrium. Endometrium is actually the part of a uterus, and the part of the uterus can be divided into three types: the endometrium, myometrium, and perimetrium. Endometrium, okay, so only endometrium remains during after the menstruation because it is innermost layer. My endometrium, myometrium, perimetrium. I don't know. No, endometrium is the one that sheds. So if there is any irregular so function. Okay, let's go through the irregular shading of the endometrium. The abnormality is usually made in extremes of the reproductive period. Normally, regeneration of endometrium is completed by the end of the third day of menstruation. Yes, in irregular shading, this desquamation is continued for a variable period of with stimulation failure of regeneration of endometrium. The possible explanation. Okay, okay. So irregular shading of a irregular shading of a normal regeneration of endometrium is completed by the end of the third day. So functional menorrhagia. Okay. So functional menorrhagia can be divided into two varieties. Okay, irregular shading of the endometrium. So the irregular shading of the endometrium is continued for a variable period as there is stimulation failure of this is due to incomplete atrophy of the corpus luteum, leading to serum progesterone level low and persistent. Endometrium reveals a mixture of a secretory and proliferative picture. Irregular ripening of the endometrium is clinical manifestation Okay, I studied irregular shading of the endometrium. The abnormality is usually met in estimable recovery period. What about the regions of endometrium? Which were actually short tissue. Okay. Irregular ripening of the endometrium. There are irregular ripening of the endometrium. There are poor formation of and inadequate function of corpus luteum. Secretion of both estrogen and progesterone is inadequate to support the endometrial growth. Okay, as such, slight bleeding occurs and continues prior to the start of the proper flow. The endocrine profile in the luteal phase shows persistent low level of urinary pregnanediol level of less than 3 milligram or plasma progesterone level less than 5 nanogram per liter. So I am reading this from the book. So irregular wrapping of the endometrium is clinically manifested as slight bleeding that starts prior to the actual onset of menses. Okay. Irregular wrapping means there is a premature ripening of the endometrium since there is deficiency since there is abnormal working corpus luteum in case of ovulatory dysfunctional uterine bleeding, ovular bleeding in case of ovular bleeding. So secretion of both estrogen and progesterone is inadequate to support the endometrium. This is due to the poor formation and function of corpus luteum. The plasma level of progesterone is low. Endometrium develops patchy areas of secretory changes amidst the proliferative endometrium. So the practice one of the spotting patchy area of secretory change amidst proliferative endometrium develops patchy area of secretory. So let's look at the anovullar bleeding. So it can be divided into ovular bleeding and anovullar bleeding. Within the ovular bleeding there is polymeria, oligomeria or functional menorrhagia, and functional menorrhagia is might be due to two conditions: irregular shedding of the endometrium and irregular ripening of the endometrium. Irregular shedding is continued for a variable period as there is simultaneous failure of endometrial regeneration. Uh, Simultaneous failure of endometrial regeneration. This is due to incomplete atrophy of the corpus luteum. Okay, there is so irregular shedding of the endometrium is due to the irregular atrophy of corpus luteum that leads to serum progesterone level low and persistent. Serum progesterone level is low but it is persistent. So it takes a lot of time. So there occurs menorrhagia. Then the volume is less. I guess the time is duration. The duration is more in case of ovulatory bleeding. It might be so functional menorrhagia might be other. So irregular shedding of the endometrium and irregular ripening of the endometrium. The irregular ripening of the endometrium is due to the poor formation of a corpus luteum. So irregular ripening is due to the poor formation of a corpus luteum, and so irregular ripening is due to the this irregular ripening of the endometrium is due to the poor formation of a corpus luteum, and irregular shading of the endometrium is due to the poor degeneration of a corpus luteum, corpus luteum. Okay. So let's revise. There is this in case of ovular bleeding, there is polymenorrhea, and so polymenorrhea is occurs after the abortion or childbirth, and in case of pelvic inflammatory disease, polymenorrhea occurs in those conditions. And oligomenorrhea is not primary but it is secondary and probably due to the unresponsiveness of a follicle stimulating hormone. This is only prevalence of follicle stimulating. And functional menorrhagia is due to the irregular shedding of the irregular ripening of the endometrium and irregular shading of the endometrium, in which the irregular shading of the endometrium is uh, due to the abnormal uh, irregular shading of the endometrium is due to the uh, abnormal degeneration of a corpus luteum, and irregular shading of the endometrium is due to the abnormal abnormal this is abnormal formation of a corpus luteum, I guess. No, irregular ripening is due to the abnormal function of a corpus luteum. So corpus luteum is important in case of functional menorrhagia of the ovular bleeding. So anebular bleeding. Let's look at the anebular bleeding. So menorrhagia. So we know that the menorrhagia is a condition in which there is increased production of a there is increased volume and increased volume and duration of a menstrual cycle. Anebular bleeding is usually excessive. Okay, in the absence of growth limiting progesterone, there is total absence of progesterone, which is produced by the corpus luteum. Due to the anovulation, the endometrial growth is under the influence of estrogen for the cycle. Okay, there is increased estrogen. It might be due to the increased amount of estrogen. Anebular bleeding might be due to the increased amount of estrogen. There is inadequate structural stromal support. Okay, there is increased amount of estrogen, and increased amount of estrogen means increased proliferation of endometrium. Increased proliferation of endometrium. Increased proliferation of endometrium. So 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 in case of anovular bleeding, which means the bleeding in the absence of ovulation, there is excessive bleeding in this case, and that is probably due to the increased progesterone due to the anovulation. The endometrial growth is under the influence of estrogen for the cycle. There is inadequate structural stromal support, and the endometrium remains fragile. Okay, the stromal support is very less, and therefore the endometrium remains fragile. Thus, with the withdrawal of the estrogen due to the negative feedback action of follicle-stimulating hormone, the endometrial shading continues for a longer period in asynchronous sequence because of lack of compactness. Okay, so when there is increased amount of estrogen, there is increased proliferation of endometrium, and since there is increased proliferation of endometrium, there would be certainly be less amount of stroma to support that much amount of endometrium. So whenever there is a negative feedback effect by the feedback action of follicle stimulating hormone, there occurs heavy menstrual bleeding, and it occurs for a longer period of time because of lack of compactness, obviously. So menorrhagia. So anovular bleeding, there might be a menorrhagia, and there is other conditions, cystic glandular hyperplasia. This type of abnormal bleeding is usually made in pre-menopausal women. So cystic glandular hyperplasia, meteoropathia hemorrhagica, Schroeder's disease. Okay, this type of abnormal bleeding is usually made in a premenopausal woman. Okay, this basic fault may lie in the ovaries, or maybe due to the disturbance of rhythmic secretion of gonadotropins. There is slow increase in secretion of estrogen. But no negative feedback inhibition of a follicle stimulating hormone. The net effect of so there is lack of negative inhibition of follicle stimulating hormone. I think this point is important in case of cystic glandular hyperplasia. The net effect is gradual rise in the level of estrogen. Okay, So there is gradual rise in the level of estrogen with concomitant phase of amenorrhea for about 6 to 8 weeks. As there is no ovulation, the endometrium is under the influence of estrogen without being opposed by growth limiting progesterone for a prolonged period. After a variable period, however, the estrogen level falls, resulting in endometrial shedding with a heavy bleeding. Bleeding also occurs when the endometrial growth have sorry outgrow their body supply. Due to the increased endometrial thickness, tissue breakdown continues for a long time. Bleeding is heavy as there is no vasoconstrictor effect of PG2 alpha. Okay, there is deficiency of a progesterone as well, and progesterone is the one that helps in formation of PG2 alpha. Now the PG2 alpha is very important because PG2 alpha PG2 alpha is responsible for the formation of a platelet plug. It helps in the formation of a platelet plug with fibrin. It helps combine with the platelet with the fibrin, and it also helps in the vasoconstricting action. So since there is lack of progesterone, there won't be more of a PG2 alpha. Therefore, the bleeding would be heavy, and there won't be any vasoconstriction to control it. Bleeding is prolonged until the endometrium and blood vessel regenerate to control it. Okay, so this was in case of cystic glandular hyperplasia. So once more, this type of bleeding is limited in premenopausal women. The basic fault may lie in the ovaries or may be due to the disturbance of rhythmic secretion of a gonadotropin. There is slow increase in secretion of estrogen, but there is no negative feedback inhibition of follicle stimulating hormone. The net effect is gradual rise in the level of estrogen with contaminant phase of amenorrhea for about 6 to 8 weeks. And there is no ovulation. The endometrium is under the influence of estrogen without being opposed by growth limiting position for prolonged period. After a variable period, however, the estrogen level falls, resulting in endometrial shedding with heavy bleeding. Okay, changes in the uterus. In case of cystic glandular hyperplasia, okay, there is variable degree of there is variable degree of myohyperplasia. Myo means muscles and hyperplasia means increase in number. So with symmetrical enlargement of a uterus to size about 8 to 10 weeks to size about 8 to 10 weeks due to the simultaneous hypertrophy of a muscle. The endometrial changes are classic. On naked eyes examination, the endometrium looks thick, congested, and often polyploidal. Often polyploidal. Microscopy, there is marked hyperplasia. So in microscopy we can see, so variable degree of myohyperplasia with symmetrical enlargement of the uterus. There is enlargement of the uterus and it is symmetrical, not unsymmetrical. In case of cystic glandular hyperplasia, there is marked hyperplasia of all the endometrial component. There is, however, intense cystic glandular hypertrophy, rather hyperplasia. Microscopically, there is marked hyperplasia of all the endometrial component. There is, however, intense. So, in case of microscopy, so just a minute. This marked hyperplasia of all the endometrial component. Okay. There is, however, intense cystic glandular hypertrophy rather than hyperplasia with marked disparity in sizes. Some of the glands are small, others are large, giving appearance of Swiss cheese pattern. Now, what is Swiss cheese pattern? So, okay, I don't know how the Swiss cheese look, but okay, this is this might look like okay. This so Swiss cheese pattern is seen in case of cystic glandular hyperplasia. Cystic glandular hyperplasia. Important to note this. Okay. Swiss cheese made in Switzerland. Okay. The glands are empty and lined by columnar epithelium. Okay. So we just need to understand Swiss cheese pattern. Why there is Swiss cheese pattern? Because there might be some glands that might are small, and there are some glands which are larger. So there are some glands which are smaller like this, and some are which are larger. So does this look like a Swiss cheese? Okay, it might look like a Swiss cheese. So it looks like a Swiss cheese. Okay, so it gives Swiss cheese pattern. The Swiss cheese pattern is seen in case of cystic glandular hyperplasia. Absence of okay, Swiss cheese pattern. The glands are empty and lined by columnar epithelium. Absence of secretory phase. Okay, the glands are empty and lined by columnar epithelium. There is absence of secretory phase. Area of necrosis in the superficial layer with small hemorrhage and leukocytic infiltration. So there might be leukocytic infiltration as well, and there is absence of secretory changes. So changes in ovary in case of cystic glandular hyperplasia. Cystic changes may be observed involving one or both the ovaries. Okay, there is cystic changes in ovaries. However, the uterus was symmetrically enlarged, and it was enlarging up to the 8 to 10 weeks. But over in case of ovary, the cystic changes is observed in either one ovary or both of the ovaries. The cyst may be single or multiple, and the fluid contains estrogens. Okay, there is cyst in case of ovary. So suppose this is ovary, there might be appearance of cyst, and that cyst is actually filled with estrogen. The cyst is of follicular type. There is no evidence of corpus luteum. Okay, confusion in diagnosis. Okay, phase of amenorrhea followed by continued bleeding per vaginum with bulky uterus is too often confused with disturbed uterine pregnancy or ectopic gestation. In anovulatory dysfunctional uterine bleeding, unlike normal menstruation, there is no uniform okay there is no uniform sloughing of endometrium up to the basal layer. This results in excessive uterine bleeding. So it might be confused with the disturbed uterine pregnancy or ectopic pregnancy or ectopic gestation generally. So the diagnosis for the this might be included in case of in differential diagnosis if it is taken. And the in anovulated and in ovulated in anovulatory dysfunctional uterine bleeding, unlike normal menstruation, there is no uniform sloughing of an endometrium up to the basal layer. This results in excessive uterine bleeding. Okay, in anovulatory dysfunctional uterine bleeding, there is a decreased synthesis of Pg2 alpha. And thromboxane as well. Due to the restriction, dysfunctional uterine bleeding of this type is absolutely painless. Okay, anovulatory uterine bleeding is anovular bleeding is painless. So in order to clear out the confusion of a disturbed uterine pregnancy and ectopic gestation, generally the patient is asked if they have performed a pregnancy test or not. Yeah, pregnancy test is positive in case of ectopic gestation as well, I guess. Ectopic pregnancy, yes. And okay, atrophy of the endometrium. This type of abnormality is commonly met in postmenopausal women. Atrophy of the endometrium. This type of abnormality is commonly met in the atrophy of the endometrium. This type of abnormality is commonly met in the postmenopausal woman but may occur in the reproductive period as final in ovulatory state of previous. So I think anovulatory bleeding is more common with the menopausal woman, postmenopausal woman, since there is no formation of a okay, since there is no formation of a ovum, there is no formation of a endometrium. However, there is some factor that might perform that might influence estrogen production, or that decreases the production of a follicle stimulating hormone. I'm taking 5 minutes break. I'll be back. Okay, there is some sort of background noise which is very irritating. I think it is problem with the streaming software. This is so irritating. Okay. So, atrophy of endometrium. This type of abnormality is common met in postmenopausal women. There is atrophy of endometrium, but may occur in reproductive period as final inambulatory state of previous metropathia. Okay, but may occur in reproductive period as final inambulatory state in or involuntary invo final in evolution. I think this is spelling mistake, but evolutionary state of previous meteorarchia. The bleeding occurs from the rupture of a dilated capillaries beneath the atrophic surface of the epithelium. So, in case of atrophy of endometrium, also there might be a condition of abnormal or dysfunctional uterine bleeding. The cause of endometrial atrophy may be due to the total absence of estrogen or failure of uterine receptors to become responsiveness to the estrogen. Endometrial pattern of dysfunctional uterine bleeding. The following are the histological patterns found in dysfunctional uterine bleeding. In majority 60% of endometrium is normal secretory normal secretory in every aspect. In 30% the endometrium is hyperplastic, and in the remaining there is evidence of irregular shedding, irregular ripening, and atrophic pattern. Okay. So endometrium is normal secretory in every aspect. Okay, in about 30%. So what I didn't understand is that this ovulatory and anovulatory menorrhagia. I didn't understand this. What does this mean? Does that mean that it only occurs? Does ovular bleeding means that it is only prevalent in uh, reproductive age group, that is between 13 to 45? Ovulation, or does that mean the ovulatory phase in case of menstruation? I think it is referring to the phase phase of menstruation rather than the age, because after both are confusing and it is not given in book that clearly. I have to look it somewhere, but anyway, let's. So, endometrial pattern in case of dysfunctional uterine bleeding. The following are the histological pattern found in dysfunctional uterine bleeding. In majority or 60% the endometrium is normal secretory. Okay, in majority the endometrium is normal. In about 30% the endometrium is hyperplastic, and the remaining there are evidence of irregular shading, irregular ripening, or atrophic pattern. So investigations. So what are the investigation? So So what are the aims of the investigation? To confirm the menstrual abnormality as stated by the patient. Okay. To exclude the systemic. So this is very important. Systemic, iatrogenic, and organic pelvic pathology. This is important in case of definition as well. Systemic, iatrogenic, and organic. Okay. To identify the possible etiology of dysfunctional uterine bleeding. To work out the definite therapy protocol. Okay, so history. First, it is to be confirmed that bleeding is through the vagina and not from the urethra or rectum. Okay, the statement of excessive bleeding is assessed by number of pads used, patches of clots. Okay, size and numbers, duration of bleeding. If ambiguity is found from the estimated hemoglobin percentage, it is better to assess the. If the ambiguity is found from the estimated hemoglobin percentage, it is better to assess the blood loss by admitting the patient during the period. Okay, first admit the patient. If there is large number of blood loss, first admit the patient, then ask for the blood loss. Among the patients presenting with the menorrhagia, only about 50% have got excess blood loss. Okay, that is it is excess blood loss is very rare. Nature of menstrual abnormality is then to be inquired. Cyclic or acyclic, its relation to puberty. Okay, nature of menstrual abnormality is then to be inquired. Inquired. It is whether it is cyclic or acyclic, and in relation to puberty, pregnancy events, and last normal cycle. Any emotional upset or psychological problem should be elicited tactfully. Use of steroidal contraceptive or IUCD insertion should be inquired. Okay, this means that we need to take the history of a we need to take the history of a contraceptive history as well. Contraceptive history as well. History of abnormal bleeding from the inquiry site. If history of abnormal bleeding from the injury site. Okay. So if there is any, we need to inquire if there is any injury or not. If there is any fistaxis or not. If there is any gum bleeding or not, or that sort of, or any signs of pelvic inflammatory diseases. A thorough, general, and relevant systemic examination is to be made an effort to find out the cause or effect of abnormal bleeding. In a suspected case of thrombocytopenic purpura, a tourniquet test is performed. So, in case of history, we need to in case of family history, we need to confirm if there is any condition of thrombocytopenic purpura. Estimation of a menstrual blood loss either directly by alkaline hematine or indirectly by pictorial chart is not routinely done. Okay, I don't know what is alkaline hematine or pictorial chart. Internal examination. So what examination? Okay, bimanual examination including speculum examination should be done in all cases except virgins, where rectal examination is to be done to exclude the palpable pelvic pathology. Bimanual examination is performed in case of non-virgins only, not in case of virgins. In case of virgin, there is a rectal examination should be performed, and it is performed to exclude the palpable pelvic pathology. Okay, if vaginal examination is required in virgins, it should be done under the general anesthesia and along with the endometrial curettage. Special investigations. Blood values. Okay, blood values. Hemoglobin estimation is done in every cases. Serum creatine test is not done as a routine. In pubertal, menorrhagia is not responding to usual therapy. Platelet count, prothrombin time, bleeding time, partial thrombus time. Hemoglobin estimation is done in every case. So hemoglobin estimation is must. Serum creatine test is not done as a routine. Okay, it can be done, but it's not done as a routine. In pubertal menorrhagia, not responding to usual therapy, platelet count, prothrombin. Okay, platelet count. Okay, platelet count on follow up if platelet count is done, prothrombin and bleeding time and partial thromboplastin time are to be estimated. In suspected cases of thyroid dysfunction, serum thyroid stimulating hormone T3 and T4 estimation is to be done as well. So in blood evaluation, we have a hemoglobin estimation test, and we have thyroid stimulating hormone T3 and T4 test, and we have prothrombin time, bleeding time, partial thrombosplastin time check as well. So then ultrasound and color Doppler. Okay, finding of endometrial hyperplasia are endometrial thickness greater than 12 millimeter. If endometrial thickness is greater than 12 millimeter, then there is endometrial hyperplasia, which is common in case of endometrial hyperplasia is common in which case of DUB. In all cases, it is all causes of DUB. Hyposcoic and regular outline, angiogenesis and neovascular signal study. Transvaginal sonography is also very sensitive to detect any anatomical abnormality of the uterus, endometrium, and adnexae. For echoic and regular outline, okay, saline infusion sonography is found very helpful to diagnose endometrial polyps. If there is any endometrial polyps, saline infusion sonography is the must. Submucous fibroid and uterine abnormality. So figure number 118. See 118. 118. 118. See picture 118. Where is it? Okay, it means this, I think. Saline infused, what was that? Saline infused sonography. Sonography is found very helpful to diagnosing endometrial polyps. It is okay. Submucous and fibroid and uterine abnormality. Then we can perform hysteroscopy. It is done for better evaluation of endometrial lesions and to take biopsy from the offending site under the direct vision. The frequent finding of polyp and submucous fibroids are often mixed with the blind curettes. Hysteroscopy and direct biopsy can be performed as an outpatient basis. H&B has replaced conventional DNC. What the hell? Is done for the better hysteroscopy is done for the better evaluation of endometrial lesions and to take biopsy from the offending site under the direct vision. The frequent finding of polyp and submucous fibroids are often missed by the blind curettes. It is one of the type. Hysteroscopy and direct biopsy can be performed as an outpatient basis. H&B has replaced conventional DNC. See page number 194. Endometrial sampling can be done as an outpatient basis. Pipette sampler is easy to use as it is blind procedure. Intrauterine pathology, polyps or mucous fibroids cannot be detected. The laparoscopy to exclude the unexpected pelvic pathology such as endometriosis, pelvic inflammatory disease or ovarian tumors. To exclude the